Bismillahirrahmanirrahim. Assalamu alaikum, respected students. I am Dr. Muhammad Ansari, Assistant Professor of Pediatrics, and today I am going to give a simple overview of cyanotic congenital heart diseases. Let's have a look on the human heart. Human heart is consistent of four chambers, where superior vena cava, inferior vena cava, bringing deoxygenated blood from the upper and lower part of the body, empties into the right atrium. The lower inferior vena cava is bringing nutrition-rich but deoxygenated blood from the liver side, and it empties into the right atrium. This deoxygenated blood empties into the right ventricle and goes to the lung for oxygenation, and oxygenated blood returns through pulmonary veins, two on right side and two on left side, to the left atrium, and through left ventricle. This oxygenated and nutrition rich blood is pumped into the aorta and goes to the whole systemic circulation and to the body for bodily needs. This is the frequency of congenital heart diseases. Cyanotic heart diseases. Tetralogy of FALLOT is the most common cyanotic congenital heart disease, affecting 3 out of 10,000 live births. 7 to 10% of all congenital heart diseases is tetralogy of FALLOT. There are four anatomical abnormalities in tetralogy of FALLOT. Number one, there is pulmonary outflow tract obstruction. Infundibular stenosis is the other name. It is not usually valvular, it is subvalvular outflow tract obstruction. There is ventricular septal defect, and overriding the aorta is overriding this ventricular septal defect, and there is also right ventricular hypertrophy. Because right ventricle wall is thickened and hypertrophied, so the apex is lifted in this condition, and X-ray will show a boot-shaped heart. If there is an ASD in addition to these four findings, then there will be this is called pentology of FALLOT. Because the symptoms may not start right at birth, because infundibular stenosis is not very severe at birth, so the condition is called pink tetralogy of FALLOT. As the infundibular thickens and infundibular stenosis increases with life, in 2 to 4 weeks or maybe 6 months, the child will start developing cyanosis. The shunting will start from the right side of the heart to the left side of the heart. Towards right to left shunting will lead to cyanosis. These patients, children with tetralogy of FALLOT, exhibit bluish skin during episodes of crying or feeding or illness, and these are called TET spells or hypercyanotic spells. Other conditions with restricted pulmonary flow also develop hypercyanotic spells. Other cyanotic congenital heart diseases where there is restricted pulmonary blood flow, there is also hypercyanotic spells. The primary pathophysiology of these TET spells is that systemic vascular resistance is decreased by dehydration or shock or sepsis or some other reason, and now blood is shunting from the right side of the heart to the left, and going to this deoxygenated blood is going to the systemic circulation and causing cyanosis. So the management steps is to increase the systemic vascular resistance by knee chest position to shut down the circulation in the lower limb so that systemic vascular resistance increases. Then administration of oxygen, administration of soda bicarb, careful administration of fluid if there is hypovolemia, administration of morphine which will cause pulmonary dilatation, and administration of beta blocker which will reverse infundibular stenosis, infundibular narrowing. Transposition of great arteries. As clear by its name, the great arteries, that is pulmonary artery and aorta, are shifted. Instead of aorta arising from the left ventricle, it's arising from the right ventricle, and pulmonary artery is arising from the left ventricle. So deoxygenated blood goes from the right ventricle, goes to the aorta, goes to body, and returns back to the right side of the heart, and oxygenated blood from the left side of the heart goes to the pulmonary artery and returns back. This oxygenated blood returns back to the left side of the heart. So these two circulations are going in parallel instead of going in series. Series is required for for normal life consistency. So there must be an abnormal connection between these two circulations for the mixing of the oxygenated and deoxygenated blood. If there is no abnormality, if there's no abnormal opening between the two circulations, then the condition is not consistent with life. So the patients will usually have a PDA or an ASD or a VSD, and if they have only a PDA, then we will have to give prostaglandin infusion so that we can keep the PDA patent. You can keep the PDA open so that the little bit of mixing takes place and bodily needs are met temporarily. Tricuspid atresia is another condition, cyanotic heart disease, where there is no tricuspid valve is not formed. So there must be some other defect for this cyanotic blood, for this deoxygenated blood to go to the right side, to the left side of the heart, and left chamber, left ventricle is pumping mixed blood into the systemic circulation as well as pulmonary circulation. Total anomalous pulmonary venous return has further three types: supracardiac, cardiac, and infracardiac. Instead of pulmonary veins bringing oxygen-rich blood from lungs uh, opening into the left atrium, they open into an abnormal pulmonary vein connections, and they into an abnormal chamber or an abnormal vein which opens into either superior vena cava, which is seen in supracardiac type, or into right ventricle, right atrium, sorry, directly, which is also called cardiac type of TAPVR, or into inferior vena cava, which is called infracardiac type of TAPVR. So oxygenated blood is not returning to the left atrium or left ventricle, and instead it is going to the left atrium or left ventricle through an abnormal opening like ASD or VSD or PDA. So this abnormal opening is keeping body oxygenation, and this condition is very difficult to treat. And if there is the supracardiac TAPVR presents with snowman sign on X-ray. This is another pathognomonic sign of this condition. Truncus arteriosus is an additional chamber which is formed at the common ventricular outlet. There is ventricular septal defect, and there is a common pulmonary and aortic opening overriding this ventricular septal defect. So this common chamber, there is mixing of oxygenated and deoxygenated blood going, and both pulmonary artery and aorta is arising from this abnormal chamber which is called truncus arteriosus. This chamber is called truncus arteriosus, and there are other defects. This is also a complex congenital heart disease which presents with cyanosis and is very difficult to treat. Hypoplastic left heart syndrome, classically it should not be a cyanotic condition, but it is not consistent with life unless there is an abnormal communication between the left and right side in the form of a PDA. If PDA is not there, then probably the child is not going to survive. So there will be PDA there because there is pulmonary hypertension, so blood will shunt from the right side to from the pulmonary side to the aortic side, and this condition presents usually at 24 to 48 hours of life with shock-like state, duskiness or cyanosis, and a reluctance to take feed. This was my today's lecture. Thank you very much, dear students.